So I'll be showing a couple of intraoperative pictures, just so you know. I'll give you a heads up in case it bothers people, but they're pretty straightforward images. Uh, so thank you. It's a privilege to be here, and I've taken care of many of you, and it's a privilege to be here speaking to you. So I'm going to put this busy slide at the beginning and at the end. These are um, some generalizations that I think are I keep in mind when I see patients with NF2. So I think not all the tumors we see are destined to cause symptoms. I'll show examples of that, so they don't all have to be removed. Some are going to just sit there and not be symptomatic. When symptoms arise, they can be symptoms related to the nerve that bears the tumor itself. The nerve can start losing function, or it can be due to displacement of the spinal cord. And I'll give an example of that concretely. Some nerves, some will grow faster than others. There's a lot of heterogeneity. Not all the tumors. Sometimes patients with a heavy burden of tumor in the spine ask me if one has started causing symptoms, are they all going to grow at the same rate? And I think we have to take each one individually. Just because one behaved badly doesn't mean they're all going to do that. And then the surgical strategy matters a lot because there are nerves that are less important than others. For example, if a tumor arises on a nerve that supplies a patch of skin in the back of the head, we don't hesitate to remove the tumor in its entirety, knowing that it'll be very well tolerated and a person may not notice it. But if it arises from a tumor that supplies the hand, then we really have to use a surgical strategy, and I'll show a slide on that, to preserve function as much as possible. And as we'll see, as I'll show you, it's easier to preserve motor function than sensory function. I'll explain to you why that is at surgery. And most of the time, we don't have to do a spine fusion. So here's an example, for example, of a patient with multiple tumors who, after at a 1-year follow-up, had no change in symptoms. And when we look at the scan, we see that there are a number of tumors here. And I think someone, even with a moderately heavy tumor burden like this, who is not having any new symptoms, where the scan hasn't changed, we can keep watching. We don't have to go in necessarily and start taking tumors out if there's been no change, and we can continue watching. It's important perhaps for the surgeon to inform the patient of what to look for. In this case, I'd be worried about the larger one at the bottom of the spinal cord. And that said, though, sometimes when we see someone with spine tumors, we can intervene because we anticipate it's about to cause symptoms. It may not have caused symptoms yet, but here's an example of a patient where there was no change on, I'm sorry, there was actually no change on symptoms, but there was a change on the MRI scan. Oh, I'm sorry. Here, oh, thank you very much.
There's another way too. If you click on this, Sean, click on this. No, with your
Mouse.
click on that, and then you go laser sling.
Oh, great. So on this patient, there was no change in symptoms, but there was progressive growth of this tumor. Here's the spinal cord, here's the tumor adjacent to the cord, and we made the decision to plan the surgery because we knew if we waited another year or 6 months, the patient was likely to have significant symptoms. And so we made the decision to go in before symptoms became significant and to decompress the spinal cord. So sometimes we operate because of the anticipation of symptoms. We say, okay, this is about to get symptomatic. We better start thinking about surgery over the next year. We try, based on the growth pattern, to extrapolate and say, okay, it looks like over the past year it's grown significantly. Let's think about surgery over the next year. When we do decide, so if the patient has symptoms, if somebody has symptoms from cord displacement, it is important not to wait too long because this is from a paper of our past 50 patients, and when the cord starts to have a cord signal change, the result is less good. These are patients who had some worsening motor function, a less good outcome after surgery. And it seems to be related to the duration of symptoms before surgery, the presence of tumor inside the spinal cord, or when the cord starts looking swollen, when the cord starts looking bright on the so-called T2 images of the MRI scan, which is a measure of edema or swelling. And when that happens in patients who have had symptoms, I think it's better to act sooner rather than later. So so I think half the battle is really thinking about, is it time to intervene, but also what is the goal of surgery? And to me, it boils down to two things. Are we trying to decompress the spinal cord because it's been shifted, there are spinal cord symptoms, in which case, even sacrificing some nerve function is worth it in the balance? And is the nerve that is causing the compression an important nerve, one that can be taken, so to speak, or one that has to be salvaged? And I'll show you an example of each, and I'll show you an intraoperative photo. So here is a surgery where the surgery may not be super straightforward, but the goal of surgery is extremely straightforward. This is the patient with a tumor coming from the T12 nerve, the last thoracic nerve. And at the top of the screen is the bottom of the spinal cord. And the patient had symptoms related to the spinal cord compression. Because T12 we can live without too many symptoms, the plan was to, at all cost, decompress the spinal cord, even if it meant taking the nerve. As it turns out, we didn't have to do that. We didn't know that going in, but the nerve was draped on the surface. So in this case, we just went after the tumor very aggressively, opened the tumor, decompressed it, and then took out the envelope of the tumor, completely resected it. But I'll show you a situation where it's a little more thorny. So here's an example of somebody where the tumor arises from just outside the cervical spine. And the tumor arises from the C6 nerve root, which is a nerve that's important for the biceps, for the thumb, for the index finger. And in this case, there's no cord compression. So if we're going to go after this, we have to be very careful that we're not creating more problems. And I'll show you a more magnified view of how this can be handled. In this case, the C6 nerve, and I'm showing you a case where you could actually see the nerve, it was draped on the surface of the tumor. The C5 nerve is above, C7 is below, and we're able to test these things intraoperatively. And we do that by touching the nerve and the tumor and recording in the muscle. Some of you have had an EMG, and it's very similar to that. While the patient is asleep, electrodes are placed in the arm, and we can test the surface of the tumor and see if there's a live nerve or not. And that's how we can do this. In the 1990s, when I was in training, sometimes surgeons would actually take the whole thing out and not test it, say, well, we've got to get rid of this. We now know that that's wrong and that you're able to actually test it. So I'll show you what that looks like. This is from this case. We touching the tumor capsule with the probe right here, no response. These are the different muscles that have an electrode. You can see the biceps is silent, deltoid, triceps, no response. But then if you touch right here, when you touch this little fiber here, you can see a sharp response for some reason in the deltoid. It's not supposed to supply the deltoid, but we got a good deltoid and biceps response. And so then we knew we could go in here. Now, this case is pretty straightforward because you can actually see the nerve. So visually, we could have just decided to spare the nerve. But there are other cases where the nerve is so embedded in the tumor capsule that you don't see it. And so we take a little marking pen, a surgical marker, and we actually draw a little dotted line where we anticipate, whenever we see a live response. So we'll put little dots on the surface of the tumor and say, okay, from here to here, this is a live nerve, and we literally leave that strip of tumor, like a little ribbon of tumor, unresected. And that way we can preserve motor function. And so in this case, it was pretty neat because the deltoid and biceps responded before surgery like so, and after resection, we actually even saw, you don't often see that, but there was actually an improvement right after resection, and this is what the thing looked like. And this little tumor had a little small nerve going into it, a little small nerve leaving it, but no major function was gained. So I'll show you, this is another case of a tumor causing a spinal cord compression. Here's the spinal cord. This is an important nerve. I think it was a C7 nerve. And in this case, we knew we have to decompress the spinal cord because the person is having spinal cord symptoms, even if it meant causing a little bit of injury to the C7 nerve because it saves the cord. But we did the same strategy. We tested it intraoperatively. We took out what we could take out, and we left a little bit behind right here, but the cord was decompressed in the process. And the problem is we can map out the motor nerve very well, but we're not that good at picking up the sensory nerve. And so when we looked at the past 50 patients, here's what happened. Here's the bottom line. If you look at motor function, most of the time it stays the same. In some patients, it improves 35%, and in a few cases, it gets worse. But sensory, most of the time, it stays the same. But if you look at sensory function, you're slightly more likely, or approximately the same, equally likely to be a little bit worse as you are to be a little bit better. So we have to be careful doing the surgery for a loss of sensation, because it's kind of you're equally likely to make it worse as you are to make it better. But for motor loss of function, taking it off a nerve, you're more likely to have a motor improvement. And graphically, over time, this is what it looked like. When the tumor is taken out of a peripheral nerve, immediately, while the person is still in the hospital, there's a little bit of a loss of motor function, but it actually is better. I think this was a 6 months follow-up. Sensory, however, doesn't quite, because you're equally likely to make someone a little bit better as you're a little bit worse, sensation was a wash. And I think the reason is we can stimulate the surface of the tumor and look for an instant response in the muscle. And so that's very precise. We touch the tumor, boom, we see the muscle fire, so we know exactly where it is. But for sensation, we would have to record over the brain. And so what that would mean would be touching the tumor for a very, very long time and sending multiple impulses and looking for a cortical response. And it's much less precise, much more fuzzy. So there's no practical way of doing it. And one other thing I'd just like to go over is the approach. It's important when discussing surgery for these tumors to always pick an approach that's reasonable, that itself is not too traumatic. So here's an example of a tumor that sits right next to the thoracic vertebrae. And this person had been advised to have a fusion for this, but there's 2 ways to do this without a fusion. It's possible to go direct posterior, adjacent to the spine, and not destabilize the spine, not to have to put screws and rods. Or in this case, it's also possible to go through the lungs with a thoracic surgeon, video-assisted thoracic surgery. And we went directly posteriorly, and I'll just show you because the muscles are not cut, but they have to be pulled out of the way. And this white line that you see here is the swelling inside the muscle as a result of our surgical approach. Where the tumor was, now there's a little blood clot right here, but a year later, things have healed very nicely, and really not too many symptoms from the surgical approach. So I think it's nice, if possible, to try to avoid fusing. And now, because we have really good microscopes and good visualization, we can usually get to the area without having to fuse. So just to sort of summarize, I think not all spine tumors are destined to cause symptoms. A lot of them can be watched. You can get symptoms from the nerve itself being affected by the tumor or compression of the cord. And when there is cord compression, I think it is better to intervene early when the symptoms occur rather than to wait, because early intervention when symptoms are starting is likely to give you better outcome than if you wait as long as possible until you really can't stand it anymore. Some will grow faster than others, and that's why it's important to just monitor, just to see what they're doing. The ones that are on non-critical nerves, we don't even test. If it's on a small sensory nerve that supplies, for example, the T11 rib, we will just take it out because there's no point in trying to, unless there's a clear delineation of the nerve, it doesn't really cause any post-op symptoms. But the ones that are on important nerves, it's very, very important to map them out. And that's when it's important to really take our time to map out the motor nerves to preserve function as much as possible. We can usually preserve motor function. It's very hard to preserve sensory function, and we try not to fuse. So that's it in a nutshell. Thank you. Yes, do you have a question, sir?
When you do the surgery,
So like,
when you're doing the surgery and the nerve is on the external part of the tumor, you said you leave a small strip of the tumor there. What do? Go in on either side and underneath it And then remove the whole tumor or just a portion thereof?
You know, what it resembles, it's almost like if I made the analogy with a fruit, oftentimes the live nerve fibers are, if it were a lemon, they're in the peel, and the inside is usually all tumor. And so we may have to leave almost like a little strip of, like of the lemon peel, containing tumor and nerve, and core out the inside.
Will that will that tumor possibly regrow in the same spot?
Possibly, yeah, possibly, but usually it's given a lot of time before that, you know.
Following up on that, when it regrows, and you have to perform surgery again, does it become more dangerous? And if so, is that still the best option, surgery, or like is radiation a better option? Or
It's a really good question. I've been in situations where I've had to go back in on a tumor, and no, you're absolutely right. Things can be a little more scarred. It can be a little bit more difficult. I think the principle we try very hard to adhere to is like to get as much out the first time around, because it'll be harder the second time. And you're right. There may be a role if it really looks like it's in a tough place in front of the cord, it's been partially resected. There may be a role for radiosurgery.
Okay, thank you very much.
Tell everybody about tumor boards and how we talk about this as a team. That might be helpful.
It's a great point. So I think we all kind of figured out from Dr. Coumans' answer just there, this is often not straightforward. And so it's a very common case at Mass General, at Children's, and many places around the country to have groups of doctors come together and try to come up with a consensus from a variety of viewpoints, from a variety of specialties. And so we review all of the complex schwannomatosis cases and NF cases with a multidisciplinary group here to say, we don't know what the right answer is, but what do we think is the best answer in terms of optimizing safety and outcome for this person in the long run? Okay,